Cutaneous Leishmaniasis, a unique presentation of nodular lymphangitis by Rajvi Patel, Priyanka Jagannathan, Christina Stoll, and Christopher Moriades for Dell Medical School at the University of Texas at Austin. Leishmaniasis is a protozoan infection with a wide spectrum of clinical manifestations, including cutaneous, mucosal, and visceral subtypes. Though less commonly seen in the United States, increasing prevalence of cases makes early recognition of this disease critical to better clinical outcomes. The following case report includes a unique presentation of leishmaniasis and highlights the importance of early detection. A 21-year-old previously healthy man presented with a 2-month history of painful ulcerations of his left arm. He first noticed these lesions during his travels, which included trips to Central and South America before arriving in the United States. Initially, the 2 lesions were small, painful red bumps on the distal left forearm, which later progressed to 3-centimeter scabbed lesions. He was seen in an urgent clinic where he was given topical mupirocin cream and Bactrim for suspected cellulitis. The lesions worsened to 5-centimeter ulcerative plaques with serous drainage and subcutaneous nodules in a spore trichoid pattern. 2 weeks later, he was evaluated by outpatient dermatology. Biopsies were taken, and tissue samplings found leishmaniasis as mastocytosis. The CDC was contacted, and samples were sent for PCR. Given the size of the lesions and lymphatic involvement, he was started on oral doxycycline until initiation of tailored therapy per CDC guidance could be started. During an outpatient follow-up, the patient complained of daily subjective fevers, chills, and abdominal pain. He was admitted to the hospital due to concern for visceral involvement of leishmaniasis. Figure 1 shows a 7-millimeter ulcerative lesion that was seen on admission, and Figure 2 shows the lesion post-debridement by wound care. During his hospital course, infectious disease and dermatology teams were consulted. Labs were notable for a mild transaminitis with an AST of 41 and ALT of 68, which later downtrended to normal levels. CBC was within normal limits, and urinalysis was negative for blood and protein. He was started on liposomal amphotericin B, which was later transitioned to fluconazole after no signs of visceral involvement was suspected. Physical examination was grossly normal other than the skin findings seen in Figures 1 and 2. Ultrasound of the right upper extremity depicted multiple subcutaneous nodules in the medial aspect of the left upper arm and forearm, suggestive of lymphatic dissemination. Figure 3 shows the spore trichoid pattern of lymphatic involvement seen in this patient's arm. PCR DNA sequencing for the species revealed Leishmaniasis pannemesis. After discussion and consultation with the CDC physicians, therapy with a 28-day course of miltefosine was initiated. He was discharged with close outpatient follow-up. The lesions showed significant improvement in size and resolution of subcutaneous nodules, as seen in Figures 4, which shows the lesion at 2 weeks after starting tailored therapy, and Figure 5, which shows the lesions after 4 weeks. This case highlights the importance of early clinical suspicion of leishmaniasis in preventing delayed treatment and recognition of the different subtypes of leishmaniasis. Treatment of leishmaniasis is tailored to the subspecies, which often takes several weeks to identify by PCR with the assistance of CDC. Given the rising number of cases of leishmaniasis due to climate change and increased travel, particularly in Texas, maintaining leishmaniasis on the differential for patients is critical to clinical diagnosis.